Hello, it's a pleasure introducing one of the authorities of interventional endoscopy in India and worldwide, Dr. Amol Bapaye. He does interventional endoscopy, US, CRCP, third space endoscopy. It's a different name on the screen. It's not him. He is, as I said, with thousands of publications in peer-reviewed journals worldwide. So, sir, can you, if you please, let us know more about endosonography?
So, good afternoon, and thank you, organizers, for inviting me to be part of this fantastic conference. I was trained as a surgeon, but then turned to endoscopy, so these are coming back to roots in many ways, and a pleasure to be here. When Dr. Mandal told me to talk about EUS in about 10 to 12 minutes, I said, rather than trying to give you a orientation as to how to do an EUS, I would rather give an brief overview of what interventional EUS is about and what we can do with that. So let me start. So I'm going to have a medley of a few videos. So obviously the first interventional procedure which we do using an EUS is biopsies or FNAs or FNBs nowadays for pancreatic head masses or distal bile duct masses, and that is one of the most common indications that we use EUS for. So EUS, the advantage is that we are scanning the pancreas very closely from the stomach and the duodenum, and we can see the mass lesion very effectively over here. And we can go through the duodenum, and one of the advantages of this is because since we are going through the duodenum, that is going to come within the area of the specimen that is going to be resected, even for a Whipple, and that's the reason EUS guided FNA or an FNB is one of the most common procedures that we do. Along with that, obviously, involvement of the portal vein, involvement of the superior mesenteric vein also can be assessed very effectively. The venous involvement is probably very accurately depicted by EUS, and we can, of course, we have to go along with the CT scan and correlate along with the CT scan also, but very often EUS will be very necessary. Just as a pancreatic head mass, you can see even a bile duct mass, and here you will see over here. So the bile duct is dilated and we're going into the duodenum, and as we go into the duodenum, when we switch on the EUS image, you'll see that this is the dilated bile duct and there is a mass lesion. How do we differentiate between a sludge ball or a stone? That there is no echo over there, and we can see that there is a significantly around a 1.5 centimeter mass lesion. And although proximal cholangiocarcinomas, EUS guided FNB is not advocated because these are patients and basically transplant candidates, distal bile duct, definitely EUS guided FNB is the choice of approach, and actually the superiority is basically, the accuracy is far superior to even an intraductal biopsy on ERCP. Very often, if these patients are otherwise quite well preserved, they can directly go for surgery and will not need any ERCP at all. So EUS not only gives you a tissue diagnosis, but also can prevent an ERCP, which most surgeons don't like in an operable patient. The other most common interventional EUS procedure that we do is drainage of pancreatic fluid collections, and this is one of the simplest procedures. We can see the retrogastric collection, and nowadays we have excellent stents, lumen opposing stents, which can be used for drainage. So what we do is we puncture the posterior wall of the stomach under EUS guidance, and the advantage is this again is a real-time puncture under Doppler control, so we can have a good control. We pass a guide wire, we dilate the tract using a diathermy instrument and then further with a balloon. And once we have dilated with a balloon, we pass a lumen opposing stent, and several types of lumen opposing stents are now available. And here you can see that you have the lumen opposing stent, which is first opened inside the cavity, and then on the endoscopic view, we deploy the other stent, the proximal flange. And this stent actually acts as a buttress. So with that, and the diameter of the stent is about 16 millimeters. We also have up to 20 millimeter stents that are now available. And because of that, what we can do is we can actually have a good drainage procedure. Even patients who have solid debris inside the cavity, we place a plastic stent or a nasocystic catheter through the stent, and then we can go back inside and actually do a endoscopic necrosectomy through the stent because the diameter of the stent is adequate enough. An extension of the pseudocyst drainage or a PFC drainage is cholecystectomy, which we can now very effectively perform using an EOS guided approach, because as we know, the duodenum and the distal bile duct are in very close proximity to each other. So here we can see this is the liver with the intrahepatic radicals which are dilated, and this patient actually has a mass infiltrating into the duodenum, and because of which an ERCP is impossible. And earlier a percutaneous approach would have been the obvious choice, but the biggest limitation of a percutaneous approach is multi-stage procedures, and sometimes these patients may be left with an external catheter. So now we have the bile duct which is dilated over here, and similar to an EOS guided pseudocyst drainage approach. Now this is like a small pseudocyst. We are puncturing it with a needle. We obtain a cholangiogram, and then we can place a stent. We have different designs of stents. So here we will obviously not place a very large stent. At 8 millimeter or a 10 millimeter stent would be adequate, and a lumen opposing stent really works in this situation because it gives us a good opportunity to actually drain the bile duct. And the other advantage is this procedure has also been extrapolated for benign strictures now, and after about 6 weeks to 12 weeks, if the stent is removed, this actually acts very similar to a surgical cholecystectomy, which has been a modality for benign biliary strictures, distal bile duct strictures, particularly related to chronic pancreatitis and other things. So the reason why we place plastic stents through these metallic stents for a short duration of time is for about a week to 10 days is because we don't want any impaction within the stent, because otherwise these patients can land up with cholangitis in the immediate post-procedure period. Sometimes even the duodenum or the gastric outlet may be obstructed, and this was a patient with a surgically altered anatomy wherein it was impossible to enter into the duodenum. In this situation, traditionally a percutaneous approach would be utilized, but here we can puncture through the lesser curvature, and we can puncture into the left hepatic duct, obtain a cholangiogram, and this patient had undergone a gastrectomy earlier, so the duodenum was impossible to access. So here there is a stricture out here, and then what we do is we pass it's a partially covered stent. The intrahepatic portion is uncovered, whereas the gastric side portion is covered, and we deploy the stent through the left hepatic duct into the stomach, which can give a good amount of palliation in these patients. So majority of these procedures are basically done as palliative procedures for advanced cancers, where drainage procedure and relief of jaundice is important. But you can see that with this patient had significant cholangitis, and because there may be some debris, we don't want these stents to be blocked in the immediate post-procedure period. That's why we place a plastic stent which we can remove after about a week to 10 days. So biliary drainages nowadays, an EOS guided approach is usually the way to go. And coming to the final procedure, EOS guided gastroenterostomy for malignant gastric outlet obstruction also, what we can do is, as we saw in the earlier video, that these patients have, there is an outlet obstruction. So what we first do is we place a nasobiliary catheter deep into the duodenum at the DJ flexure, and saline is irrigated through the catheter, stained with methylene blue, and maybe later on subsequently with a little bit of contrast, and that distends the bowel segments and through the posterior wall of the stomach. And of course we have to give this patient Buscopan or glucagon to relieve the peristalsis, and we directly puncture using a cautery enhanced lumen opposing metal stent, And here we can see that this is the cautery enhanced lumen opposing metal stent which we have actually deploying inside. And this stent has a very strong lumen opposing metallic force. So the stent width is only about 1 centimeters, but it has a very strong lumen opposing force which actually pulls the jejunum back upwards onto the gastric wall and can create a good anastomosis. The diameter of this stent is 20 millimeters, with which it can give us a good approach. So these patients can be relieved of the gastric outer obstruction significantly. Here we can see that the stent is being deployed, and in a minute or so you will see that the stent is the endoscopic view, the stent is deployed, and the blue stent fluid which we had irrigated into the jejunum is now flowing backwards into the stomach, and this can give a good response. And here we can see on a contrast swallow also, contrast installation, that the contrast is flowing directly into the stomach, from the stomach into the jejunum. So this was one video, and let me play another video where actually I have a specific procedure which I would like to talk about. And this was a presentation which we presented at the American College of Gastroenterology recently. So this patient was actually a 77-year-old male with a history of cholecystectomy and had a surgically altered anatomy because of a post-gastrojejunostomy for the pyloric stenosis. And this is the MRCP, multiple very large stones in the bile duct, and it was impossible to reach the papilla. So the plan was to create a EOS-guided hepatogastrostomy, and after 1 week to perform cholangioscopy through this access route. So we punctured the left hepatic duct through the stomach, obtained a cholangiogram. We can see the stones over here. And then we proceeded to perform the hepatogastrostomy by dilating the tract over a guide wire. And here you can see that the stent, the balloon, using the balloon, we are dilating the tract, and now the stent is coming in. Now here we are using a fully covered stent, basically because the plan would be to remove the stent after the therapy is completed. So if we use an uncovered stent, we do not have that opportunity because the stent will get embedded. But we are using a fully covered stent, especially stent which has a lasso over here. So this is the blue proline, which is the lasso. And we place a plastic stent through that, as is a usual practice, for about a week. 1 week later, we go in, we remove the plastic stent, and we pass a single operator cholangioscope through this metallic stent through this access route into the intrahepatic tree. And here we can see large stones in the bile duct, which can be fragmented, which were fragmented using a whole beam laser. And you can see stone fragmentation being done effectively. After that is performed, we passed a guide wire into the duodenum, distal to the stricture. There was a stricture also at the duodenum. And then we passed the scope, the cholangioscope, over the guide wire. And this is the view of the papilla that we saw from the bile duct side, which is not a very common view that we see. And we dilated the stricture using a balloon with which you can have a good opening. And obviously we do not expect that this will be the final procedure for this patient, but what the plan was to push the stone fragments using a balloon into the duodenum and then place a pigtail stent right from the duodenum into the stomach through this thing. So the clinical implications is, in these kind of complex situations, we either have an enteroscopy guided approach or a EOS guided approach. An enteroscopy guided approach, the efficacy is much lower as compared to an EOS guided approach. And whenever we need a cholangioscopy, an enteroscopy guided approach cannot work in any case. So that's the reason we chose this approach. And using this approach, we got a near total clearance at the first session, and 3 months later this patient underwent 1 more session of clearance and laser lithotripsy, with which complete clearance was obtained. The plastic stents were retained for another 3 months, and after which both the plastic stents and the metallic stents were removed after confirming that the stricture had opened up after 2 sessions of balloon dilatation. So with that, I would once again thank all of you all for a patient hearing and be happy to take any questions.
Thank you very much for your nice presentation. Any questions on the procedure, please? I think, thank you.
I'm Dr. Sadaf from Srinagar. I just wanted to know that you have done all these procedures are really exciting to be known as a new advancement beyond diagnostic work of US. What anesthesia you are using and what is the average time duration? And I would also like to know the long-term follow-up on the benign indications like bile duct strictures, of course in special circumstances, and stone wherein you have left number of cases done and the long-term follow-up. You have left a metallic stent in them.
Right. So the first question was about anesthesia, and obviously based on which procedure we're talking about, the time will change. But most patients are done under propofol sedation. Some of the more complex ones like a gastrojejunostomy or hepatogastroscopy, sometimes these patients are under general anesthesia with intubation. But FNV or an EUS guided fluid collection drainage typically would take not more than 10 to 15 minutes. A gastrojejunostomy can take sometimes longer, or a biliary drainage can take sometimes about 25-30 minutes on an average. That is the case. The next question was, I think, regarding the use of stents in benign indications and the long-term follow-up. So long-term follow-ups are coming up now. These procedures have been in practice for the last 10 to 15 years, and although they initially were performed for as palliative indications for malignancies, there is significant data which is coming up for benign indications. One important thing that has to be remembered is metal stents that are being used have to be fully covered stents, and these stents have to be removed after a period of maximum about 6 months. Otherwise, the stents can get embedded, and that can create a lot of heartburn for the patient as well as us. But if these stents are removed at the right moment, and because there is a distal obstruction which is persistent, the biliary drainages last much longer. See, we've also seen about some of the choledochoduodenostomies, surgical choledochoduodenostomies also stricture over time. But typically 80 to 85% VTC rates have been described in benign indications over a long term. So that is what the thing is.
Sir, regarding that gastroenteroscopy, jejunum is mobile structure.
Yeah.
So how do you fix while doing gastrojejunostomy? Or it's a gastroduodenoscopy?
Okay. So it's not actually a gastroduodenostomy, but it is not a gastrojejunostomy either. We actually target the DJ flexure because there the jejunum is relatively fixed. It's impossible for us to actually. It is a gastroenterostomy. That is the reason we call it a gastroenterostomy. It's not a gastrojejunostomy or a gastroduodenostomy. But at the DJ flexure, it is fixed. There are 3 techniques. I did not go into the details for want of time, but there are 3 techniques by which one can do the procedure. There is also a special double balloon kind of a catheter which is used in some situations. But that most of the times we are using a nasobiliary catheter to instill fluid at the DJ flexure, and we give glucagon. Buscopan also may not stop peristalsis completely, but with glucagon you can have a completely aperistaltic segment of the bowel for about 30 to 40 minutes, and the other thing is that we are using a stent which is a cautery enhanced stent. So with the cautery enhanced stent, with a high current, we go with a single puncture through the gastric wall, through the jejunal wall, through and through. So that is what actually prevents, displacement. Of course, an occasional displacement can occur. Hazards have been, complications have been reported with this procedure when the stent has been deployed in the peritoneal cavity, in which case you have to go in and pull it out and then close the hole with clips and other things. But that is how it is.
Sir, Dr. Rajesh from Bengaluru. My doubt is there any role for therapeutic US in the setting of recurrent pyogenic cholangitis with multiple strictures and...
In recurrent pyogenic cholangitis, I think an interventional US would have very limited role to play because the strictures are multiple, they are multifocal, and they are extending all throughout the duct. So in that kind of a situation, any kind of a stent, whether you place it through the papilla or through the stomach, it's going to have only limited efficacy.
Thank you.
Thank you very much.
Thank you very much.
Good morning, sir.